All right.
Got it. All right. So
So
that's what Cam learned at the liquor store.
I did. They got
anyways,
so much good information there.
How's it going, Dr. Amsterdam? Getting to some more important things. Thanks for joining us.
What's going on, guys? This is Nate.
Hey, Nate.
Where are you?
I'm standing at the light rail. We're going to the treatment court rally at the Capitol, so it's going to be really loud. I'll have to go back on mute, but I'll be taking part.
Cool.
Got it. Thanks for joining us, Dr. Amsterdam. Hey, Stacy, I know you're usually going to have a crew join you from Bethesda as you're slightly off camera.
Hi. Yep. Some people will be here, I think, in a little bit. Yep.
Got it. I love that. You always have that duck in. It's nice.
I know. I like it. I can eat in private.
Hey, Ryan. Thanks for joining us. This is Ryan Kelly. I don't know. Are you joining us from Kook, or where are you joining us from?
Yeah, I'm joining you from Kook. I just took you off mute here. Glad to be here.
Thanks for joining us. Hey, Sally.
Hello.
How's it going?
It's going well. How are you guys?
Good. Where does this find you today?
I am in my office in Ortonville.
Got it. Well, thanks for joining us.
Yeah.
I see Peter Schultz just joined us from the Naran Clinic. Thanks for joining us. I see Twyla Mersu. Hey, Twyla.
Oh, thank you. One correction. I'm from Nura.
Nura, sorry.
It's okay.
Yeah, I'm sorry. I misspoke. I'm sorry.
Right.
I promise I'll get that right next week.
Okay, no problem.
100%.
Glad to be here.
I will practice afterwards.
I caught that, but then I thought maybe I've just been pronouncing it wrong.
No, that was me. That was all me. Sorry. God. Hey, Twyla.
Hi. I've got Mackenzie Nordham here. She's a psychiatric mental health student that's working with me today. So
cool. What was her name?
Hey.
What was the other person's name?
Her name is Mackenzie Nordham.
Got it. Thanks. If you wouldn't mind just sending that to in a chat to Roxanne, just so that she can catch up, I'd appreciate that. Looks like we got other folks joining us. Hey, Marshall.
Hello, everybody.
And Sarah Ames. Hey, Sarah. I don't know if Sarah can hear us, but hey, Sarah, whenever you have the chance to join. I see Diana Moncourt is joining us. Hey, Diana. Diana, I can't recall. I apologize. Where are you calling in from? All right, well, for the folks that are joining us, I see somebody that just joined who's listed right now as PCM 340. I think you joined us last week, but I can't recall how you're joining us.
Yeah.
Hey.
Hi, Thomas Recht. I'm a psychologist here at North Point working with Suboxone providers here at North Point.
Got it. Thanks for joining us, Thomas. Appreciate it.
Yeah, I enjoy it. Thank you.
Thank you. And hey, Dana from South Country Health Alliance, I appreciate that. I see you have no mic or camera. If you need, we can help you out with that. So if you want to shoot a note to Roxanne, we might be able to send you a mic and or a camera to try to help you out connect. But let us know if we can help you out. And I see A. Trulson. I'm not sure who that is joining us.
Angela from South County.
Gotcha. Hey, Angela, also from South County. Cool. And then Peter asked the question, can I get permission to record this session and other sessions? Actually, we do record these. We just don't have the bandwidth to post them on the net. So if you want to see this later, you can just send an email to Roxanne and she'll send you a link to all the video. We're still trying to figure out how to archive that appropriately and within the bandwidth that we have. Thanks for the question, Peter.
Yeah, great. Thank you.
And hey, Tracy from MHA, good to see you. So we'll kind of start things rolling here. Just a few announcements then. And we're going to, by the way, just kind of coming back again, we're going to try doing this week what we did last week. We're actually going to lead with the case first and have more of a discussion and then kind of finish up with the didactic. But I think a lot of the stuff we're going to discuss in the case, we're actually going to be pulling up some of it actually with the didactic, but going to it a little bit more specificity. with our special guest today, Jesse Powell. Thanks again for joining us, Jesse. Jesse's one of the physician assistants in our GI clinic at Hennepin who focuses a lot of his time on hepatitis C. So we're going to chat more about that in a little bit. And I know lots of folks around this who's already on have kind of started to explore that space, so I'm excited for that conversation. Other things coming up, just a few just general things to know. It's always most helpful if you manage the sound on your end. So make sure to remember to mute yourself. We can always mute everybody, but then it's hard to make sure that we know how to have the conversations going. So if you have anything else that you want to share or ask, it's easiest if you mute yourself, then you can kind of unmute and jump in whenever you have questions, comments, or other thoughts. And then as much as you can, please, I invite you to use video. It's helpful for everybody just to kind of have the conversation with somebody that they can see, both for now and having the conversation as well as kind of down the road as this continues to build. It's just a really nice community that starts, and video is a part of that. Here, just kind of letting folks know announcements, upcoming ECHO sessions. On the 16th, the next 2 weeks here, Dr. Ann Pilkus from Health Partners is going to be joining us. She was one of the highlights from the boot camp, and we asked her to come back to give more nuts and bolts about how she's an addiction specialist, internist by training, who works in the pain clinic for Health Partners. So she does a lot of kind of the nuts and bolts of tapering people from high-dose opioids and getting them onto buprenorphine when they're at risk. So really great presentations the next 2 weeks coming up, and then we're working on a couple of things towards the end of the month and into June. To highlight some of the things that are going on at CHI St. Gabriel's with Kurt Devine up in Frostbite Falls. They've got a couple next few sessions you can see there. So next week, Kate LePage is going to be talking about sex trafficking and how that fits in with addiction. Maria McAllister on the role of pain rehab and the management of pain and opioids. And then coming up in June after a skip, and I don't know, Kurt, are you guys just skipping a week or just not sure what's going on at the end of May?
No, that's to be announced.
Okay. And then Dr. David Ring, what is Dr. Ring going to talk about, Kurt?
He's an interesting guy. He's an orthopedist, and he does a lot with opioids. He's out on the East Coast. A very interesting talk about how they have changed how they prescribe for all the surgical groups out there. We saw him speak in Atlanta, and cool. So we asked him if he'd come. So it's going to be a good talk. You may want to see that and then maybe tap into him for yours. I think it's going to be really interesting.
Awesome. Thanks. So that's kind of what's coming up. If you have any other thoughts, people that you want to see or you've heard, please let us know. We're always looking for more resources and people to jump in. Kind of moving on then. I think that might be all of our announcements.
Okay, I want to do it.
And so kind of jumping to the case, we'll pull it up here. Alex Hubble is going to be presenting it. Alex is one of the addiction fellows that's joining us here at Hennepin. And the addiction fellowship rotates between the Minneapolis VA Medical Center, the university, and then here at Hennepin. So Alex has a patient that we see in our office-based clinic that has Hep C. So I'm going to kind of pull that in with Jesse's thoughts, but also has some challenging things that are happening these days. So I think it's a great case just to kind of further the discussion per our usual opioid and addiction management. So I'll pass it off to you, Alex.
Thanks, Brian. So, yeah, we're seeing a guy that I saw on one of my first days on the inpatient consult service. Took a while to get him in the clinic, and now I've been seeing him in clinic for a couple months. He's a 49-year-old from Boston who has a history of different addiction issues as well as hepatitis C that is, per his report, chronic. One of the challenges is that we don't have records to corroborate some of his story. But he got treated. His thought was, his recollection is that he got treated back in the interferon treatment days a number of years ago. So anyways, I'll give you a little bit more of a background. 29-year-old, his drug use history is, he reports a history of opioid use, and his chart review and his discussion also reports a heavier concern with IV cocaine use. And as I'm seeing him more, a lot of concerns with alcohol use as well. He has type 2 diabetes with peripheral neuropathy, and like I talked about the history of hepatitis C. I'm seeing him weekly for buprenorphine maintenance, working on
$800 billion on track.
Looks like, hey, Tracy, it looks like your mic is picking up a conversation in the background.
And we've already started. So
I don't know, Tracy Radke, if you can hear us, if you could mute yours, otherwise we'll kind of, there we go. Thank you.
So one of our recent goals is to try to get him to cut down on alcohol use. We have mutually identified a goal of him quitting alcohol. And interestingly, his reports of drinking have actually gone up despite him saying he's cutting down. And there's a lot of inconsistencies in his reporting and his follow-up visits. One of those being his goals of trying to establish primary care to get his diabetes care better, as well as trying to establish with the infectious disease clinic to work on his Hep C treatment. Those are follow-ups that he has continued to not make, and continue to report struggles with trying to call to set up appointments or other issues with phones. And at the same time, he doesn't have any problem coming to our clinic every week for his maintenance buprenorphine. He's homeless. He has a lot of relationship concerns that he uses as a reason for his recurrent alcohol use. He is working with our therapist in clinic, but is not wanting to increase behavioral treatment in any other way, and does not want to add more pharmacotherapy for his alcohol use. So we've had, one of the concerns obviously is the Hep C and trying to get in for that treatment, but also just all the other stabilization that we need to do for his social picture to actually improve the rest of his outcomes. So we talked about the interferon history, a lot of incarcerations, a number of felonies that are making it difficult for him to move forward with housing. Certainly heavy drug use, and that was as recently as his last hospitalization in March. So he comes in his presentation behaviorally, he definitely talks about traumas and cries a lot in our appointments. Reports depression, insomnia, all these things, and is amenable again to some therapies, but not a lot. And yeah, I think that kind of covers the range of his clinical background. We can kind of take questions about clarifying things. Would you agree?
Let's kind of finish that. So here you can kind of see what his recent labs have been. In particular, just to note, we can go into this more if people have questions about it, but you can see the ethylglucuronide, the urine ethylglucuronide, that's a measure of the last few days of alcohol use. Consistently, his have been, his ETG is greater than 50,000. That's kind of the max limit of ours. And then there's an ethyl sulfate, which is has a shorter half-life. And that's also generally been pretty close to 50,000. So essentially he's drinking more like, as opposed to what he's saying, he's probably drinking more like at least 8 to 10 equivalents a day or more, but it's beyond kind of our upper limit of being able to measure it.
And his previous reports from before this week, when he said he was cutting down, he was conveniently only drinking the day before he came in, and would not say, he would deny drinking more than that one day beforehand. The amounts would vary, but yeah, it was never consistent with the quantification of the ethylglucuronide that we would see in our lab results. When we had him, when we first visited with him, we got his entire sort of picture set up to initiate Hep C treatment, noting, the other hepatitis testing, PCR testing, genotype, all these things, liver function testing, and it all is, we're sort of getting him set up appropriately. We'll see the details of that, I guess, with our presentation later. And so his mental status exam, it really varies, and he is expansive and circumstantial to a point where it's hard to keep a therapeutic conversation going without getting into stories or other anecdotal things that he brings up. So he's hard to nail down in a lot of ways, is kind of the gist of it. But doesn't have any severe features of psychosis or disorganization. And we talked a lot about track marks, and we continue to look at that. It's possible to hide those things, but that is something that I kind of keep an eye on with my physical exam as well, with this history of IV drug use specifically.
Question?
So kind of just to summarize then, so this is wow. Roxanne's kind of
try something different.
She gave a little color commentary there, so to speak. So this, in summary, is a 49-year-old man with a history of IV drug use, self-reported severe cocaine use disorder, although perhaps in remission, given we haven't seen any since he's been with us, although he reports a history of abscesses. Opioid use disorder, unspecified from his report, now on buprenorphine. Severe alcohol use disorder, with type 2 diabetes, peripheral neuropathy, and chronic Hep C, maybe not history of treated, but currently has a chronic infection. So he's currently on buprenorphine management, but I think right now, as many folks, as you kind of enter this space, there's this question mark around what do you do with kind of the other substance use? So I think the two questions that we can discuss today is, now with this guy, history of opioids, stabilizing from that perspective on buprenorphine, yet his alcohol is clearly a major issue for him. Kind of where would we go next? And then the second thing that I want to we'll address the substance use first, then we'll come back to more his chronic Hep C, and I think we can have a discussion about that in the context of the substance use, because in many ways this is exactly the patient that many people want to get treated for Hep C, given the risk of transmission to other people in the community. And at the same time, this is a patient that may be one of the most challenging to treat. And so I think that's kind of the discussion we want to have with Jesse here. So first off, clarifying questions that folks may have about this patient. Things you would want to know if he showed up in your clinic. Yeah, Marshall.
To clarify again, the records from 2006 or whenever it was that he previously was treated, those are not available?
No, we haven't. I was able to nail down one place where he was seen in Boston for a couple of years, and I'm still awaiting the records through the mail that they said they would sent last month. And he was not sure about getting records from his previous incarcerations. He believes he was treated for Hep C while he was incarcerated, and is not able to get us that record.
Is anything known about his stage of fibrosis or liver damage?
So he says that he was previously evaluated, but he doesn't have any of those records, and he's very vague. Based on his other lab values, that I didn't put on that sheet, but right now, from his liver function tests, his transaminases are normal, essentially. His total bilirubin is only 0.5. He's got a normal INR. His albumin was essentially 4. His platelets was 165, so kind of in the low end of a normal range. So overall, we think he's got good synthetic and metabolic function by proxy. That said, I don't know if he's got any hepatic steatosis or if he's well-compensated cirrhosis. I don't know that. Any other questions, clarifying thoughts?
What's his family situation?
So whenever we talk about support, it's always his fiance who comes to the appointments often. And she has family in town, and there's varying levels of support from her family. They were actually living with her family for a little while. And it seems like no matter what, relationships don't end up staying in any kind of stable state. And I guess I will say one thing: he has an ex-partner with a child, and his fiance is very against him being in contact with either of them. So it's a big source of distress and anguish for him, and he brings that up once in a while. I don't believe he has any other close family.
Yeah, Marshall?
Ask about.
Do you think he understands the connection between his alcohol use and his hepatitis? I mean, or the complicating effect of that on his hepatitis C. I mean, is he aware of that?
Yeah, good question.
That's a good question. I think he I don't know exactly. I haven't asked that specifically. And there's another question here. How controlled is his diabetes, his A1C and his glucose? He, being homeless and living from hotel to hotel, I asked him from time to time. He does meet with a diabetes educator because we try to schedule those appointments on the same day as mine. And it seems that they are continuing to try to work on that. And he had a 2-week stint where he was using a breathalyzer due to some court-ordered alcohol concern. I think it was a DUI, and his A1C and his sugars were fantastic for that 2 weeks. Once he started drinking again, his sugars went back up. His A1C has not been in the controlled range from what I've seen since I've known him.
No, his last A1C was in late February, and it was 13%.
Okay.
This is Kurt. I'm not sure if I missed it, but what is his alcohol treatment history? Has he gone through many times?
He's been through a lot of different treatments through incarceration, through counseling centers. The one in Boston was the most recent one that he reports was a good, well-rounded program, but he's very resistant to further treatment at this time. And I don't know his exact history of inpatient treatments.
And how about medication trials?
He's on gabapentin currently, and we tried to get him on topiramate, and he was resistant to that. He had not tried that before. And I don't think he's been on naltrexone before, but I'm not sure.
Okay. Do you get the sense that he has, it sounds like he might have kind of poor health literacy, as far as like connecting the dots between alcohol use and diabetes and alcohol use and HCV. It might be that he also doesn't have a really good handle on, kind of what a standard drink is. And so, he might say I have one drink, but it could be a pretty tall drink, or a really strong beer, or, I had a 6-pack, but it's a 6-pack of tall boys or something. And so maybe there could be some education received on that.
And before we get to the recommendations, I think, do you know how he thinks about it? This is the question.
Yeah. So in general, I think he, the way when we try to pin down the amount that he's drinking and the episodes, his reporting varies to a degree where I don't really have a sense of what is happening, and what he knows. And with his goal of trying, of wanting abstinence, that's what we tried to focus on is with difficulty pinning down what's going on and not knowing what he's telling me is true, just trying to go full-scale abstinence, it seems to be the most appropriate approach, and that's what we've been trying to anchor on to avoid any of that wishy-washy numbers, basically. But I get the sense that he both minimizes and doesn't quite understand the equivalencies involved with that.
Does he really want to be sober from alcohol?
That's what he tells me. And last time I saw him trying to pin him down and saying, you really have to stop. This isn't going to be congruent with our treatment course, and we will have to make significant changes if you're not able to. It seemed like being a former prisoner many times, he seemed to give me positive feedback on the fact that I'm trying to get him, sort of give him orders in a sense, or give him various clear instructions on what to do next, and having that kind of oversight. He said it was going to be helpful for him. So we'll see how that pans out.
Yeah.
Any other clarifying questions before we go to kind of next steps just around the substance use, and especially as it relates to his buprenorphine?
Alex, were you just saying that he wants you to be like the authority figure for him?
Yeah. Yes. And we built up a rapport, and what he says, he trusts me, and he likes the fact that he can trust somebody and they can try to hold him accountable. That's what he's telling me. The last question too, has audit or any other screening tool been used? We were looking at alcohol use and the amounts and whether or not we could give him an alcohol use disorder. And with his recent failure to stop using, lack of recognition of the medical consequences and all these things, we were able to diagnose him with a severe alcohol use disorder by criteria. So we were mindful of that screening and the appropriate diagnoses for his alcohol use.
One final question for me. What does he like to do for fun?
Well, so one thing, when a recent drinking episode, he said he went to a strip club that he hasn't gone to in a couple years, I guess. His activities in general are focused on trying to maintain his hotel housing and doing his, basically he does body work on the street. He'll stop people at stoplights and offer to do their body work. And he says, you can pay me when I'm done if you like the work. And that's how he gets his income right now. He doesn't really talk about fun otherwise. He's just trying to find a stable situation where he can just relax. I try to ask him what his future looks like once he actually gets there. And he talks about wanting to move to California. I can't really get a sense of what his life would be like if he wasn't in this homeless chaos kind of picture, or what normal looks like to him.
Okay. So kind of transitioning then, thoughts on where you would go next if this guy showed up in your clinic? Where would you go next? Yeah, Lauren.
I'm curious to know how motivated he is to receive Hep C treatment.
So when we first told him, he was crying. He was very upset. He had all sorts of discussions with his fiance. He brings it up from time to time. He's giving me some lip service to it. And at the same time, he didn't show up for his appointment, even though we very specifically talked about that follow-up the Friday before the Monday appointment. I don't know. I don't think he's as motivated as he tells me. And I'm not sure what the disconnect is.
I know we've had a challenge getting insurance coverage for a lot of patients for Hep C treatment because you have to prove that patients are not using or have some agreement to be free of substances, and that has been a challenge for some of our patients here.
Most definitely.
Yeah.
I agree. We'll definitely come to that. And yeah, and I think this gentleman, from my experience of working with Alex with him, he's very much, I know what you want to hear.
Mm-hmm.
So I'll tell you what you want to hear, and it's really hard to tease out behaviorally what he actually wants to follow through with. Any other thoughts? Where would you go next with this gentleman? Yeah, Marshall.
I guess I would probably just try to start seeing him on a regular basis while asking my staff to try harder to get records of what some of his treatment has been before. And maybe you've done that already, but I'd be reluctant to start many therapies without first knowing what's been done previously. And in the meantime, I think getting to know him or building more of a relationship with him might be sensible. And I wonder, by the way, if that should maybe be done with his fiancée present as much as possible. So she's got some influence in it.
Yeah.
I like the idea of looping the fiancée in with the appointment, and she has come from time to time, and I think maybe I'll start asking her to be in some of the visits. We are seeing him every week currently, and I told him the first step forward is that we will increase his visit frequency to twice a week if he's not able to stop drinking alcohol. So that's definitely been our plan. Our number one plan is just continuing frequency of visits to ensure we're doing everything possible to help.
Other thoughts?
Hi, this is Thomas Recht at North Point. I'd like to just sort of reiterate this idea of motivation. I would wonder if his fiancée is the current order giver, and if his comments are more about saying what she wants him to hear, or what she wants to hear him say. And I'm not hearing a lot of motivation in him at all. Your questions about future plans, if he ever got to that peaceful place, didn't seem to involve her at all. I just don't see her anywhere in his thinking, and I suspect he's there just to appease her and to keep that aspect of his life hopeful or something.
I didn't, I guess, touch enough on their relationship. He's very much thinking that she is his main support, and a big reason for, basically a person that he cares about a lot and doesn't want to disrupt their relationship despite the distress. That's part of his daily life with her. He won't go to treatment or work on housing away from her. He wants to make sure that they're together in that whole process. And that future look is actually one of the things he's talking about, moving to California, where her family lives. So more of like something that's because she has a bigger family set up than he does. Having that be part of his life sounds like one of his possible goals. And that being said, I agree. There's been some encounters, especially with the initial appointment when we talked about the Hep C, where there was a disconnect between what he's saying and what kind of their interaction was around the topic. So, I don't think he's doing things for her specifically. I think he's doing things for himself. And at the same time, she definitely has a role in this dynamic that we could definitely tease out more to understand better, where he's going to go and why he's doing the things he's doing. So I like that comment.
So I'm curious, Ryan, I know you've never seen a patient like this at Kook ever before. How
Right.
do you approach this?
I mean, I agree with a lot of the comments. It's all about establishing, it sounds like you guys already have the rapport, right? We've got one thing he comes in consistently for, not to Suboxone, right?
Yeah.
That's to prevent opioid withdrawal. And so then trying to build everything else around that. The other healthcare stuff, because me being able to do Suboxone plus primary care, I try and squeeze everything in. And then trying to find out, well, why is this, why is your A1C uncontrolled? Does it have anything to do with not having a refrigerator to store your insulin? But really trying to frame it, from that standpoint. Because we know he's coming in consistently for one thing. And, even if the current state rules were changed, I probably wouldn't be treating him with Hep C at this point anyways, unless he could prove that he'd take any of his other medications consistently, if that makes sense. It'd be more trying to find out what his barriers to consistent adherence is.
Yeah, got it.
I like that a lot. Yeah.
Other thoughts, recommendations? What would you do next with this patient?
I got a couple thoughts. Hopefully my background noise isn't too loud here.
Yeah, Nate, go ahead.
Well, I think what the last comment was great. Like, just take what's working and sort of build on it. I think that's a great idea there. And I think I'd want to ask about what the barrier to treatment is, if it's something that happened in the past, or what's going on now. It sounds like he wants to be around his girlfriend or fiance. And then I think that the question of motivation for Hep C treatment is a good one. But I think the way that I would approach it is like, you want to do something about your Hep C. Your drinking isn't helping. Help me understand the discrepancy there. Like, what is that about? And for some reason, that comment about you being the authority figure or him wanting you be like previous probation officers or law enforcement people was curious to me. I wonder to what extent like that's the case, and some exploring around his experience there.
And I think one of the things that Roxanne mentioned here offline was kind of with that in line. It's that question mark around what's his own personal self-efficacy regarding to his ability to either control his diabetes, cut down or stop his alcohol use, or kind of get to whatever the next step is. And it's quite likely that he just has an incredibly low self-efficacy, which is kind of why he's asking for somebody to tell him how it is. Any other thoughts in terms of where you would go next if this person showed up in your clinic? Kurt, or I don't know, Kurt, if you have any other additional thoughts?
We've had, even though we're in the country, we run onto situations like this with some frequency. And I think a lot of times, you talked about the housing, and obviously that's generally where we go with our social worker first, because unless you get at least one stable thing set up, it's hard to go anywhere else. But I think our success rate at that is low, because oftentimes these patients kind of like the way they live. I mean, we actually find them places to live, and all they've got to do is go fill out some forms and do a couple things, and they won't show up for it. And the reality is sometimes they really like the situation they're living in. They move around, and they'll keep coming back to see us, but they'll never fix any of those problems. So it's always difficult. In our game, of course, we don't treat hepatitis C, but I wouldn't even send him yet because everything else is still in chaos. And this is going to take a lot of time. We have a number of these going right now.
Yeah. Great points. Yeah.
I agree with that. Is the psychologist or behavioral health person he's working with, are they Do you know what they're focusing on right now? Are they focusing on the depression? Are they focusing on the trauma? Are they focusing on the substance use?
Yeah, so Mark Rosenblum, our psychologist in clinic, has been seeing him, and their focus has been mainly, well, from the patient standpoint, it's been mainly on sleep. And Mark's understanding is he's just trying to just get a sense of what's going on with this guy, what his motivations are, and what he wants to accomplish. And what gets in the way is storytelling and just not being able to kind of stay on topic. In their 30-minute sessions, they don't have a strong game plan yet even started. So even there's disconnect between the two, the psychologist and the patient on what they're actually talking about.
Sure.
Yeah. And
I think
hard to reconcile.
Yeah, Dr. Rosenblum is a sleep expert, and so I think he's keying in on something and maybe kind of establishing early success in one area can help with motivation and getting some kind of momentum going.
Definitely.
But I see this guy as someone, he's not from here. His only connections are with people that, that are his fiance's family. He spends most of his time just trying to keep housing. I agree with Kurt that, stability in shelter is going to be very important. But quickly, even before addressing trauma, just trying to establish some healthy alternatives to substance use. Right now, feeling altered probably feels better than his everyday experience. But if there's other things in his life that are also enjoyable, that he might enjoy, kind of developing those healthy alternatives to alcohol use, that could be one place to start, is just to kind of build his repertoire.
I like that.
And just to call it, I see that I'm sorry, I don't know how to pronounce. I think it's Tigist Alpine sent a note in. I don't know if you want to say your comment about audit. But the comment was, I'll just kind of jump in, is potentially using a screening tool where it's just for the patient then can identify their own severity of alcohol use instead of somebody else commenting on it. And then trying to use that as kind of a basis for screening and brief intervention to help manage. I think that's a great point. I think it's one of the struggles in that, and I think it's the strategy around how to use the brief intervention. Brief intervention has been shown to be effective with motivational intervention to try to help people engage in treatment. But it's once people have that moderate to severe alcohol use disorder, there's really no value in actually helping people to cut down their alcohol use because the addictive behaviors really kicked in and they've lost control. So I think it may be an opportune way to kind of approach that and say, here's why you need to engage in some other kind of therapy, whether it be medications or other kind of treatment program. But I think that's that tension between expert and how to manage the person who has a severe alcohol use disorder. I think kind of being mindful of time, I'm going to kind of pull this together again. And I also want to ask Jesse just to comment a little bit. This patient from a Hep C perspective and even the liver perspective, I don't think anybody's recommending treatment for his chronic Hep C at this point in time. Is there anything that you would do differently from a GI perspective and how you would either counsel this patient or where you would go next?
Yeah, I think you guys kind of hit on it a little bit in passing about the connection between his Hep C and his alcohol. I think that's a really important thing for him to understand because we know that there's rapid progression of fibrosis when you drink heavily when you have hepatitis C. So he's at much higher risk for progression to cirrhosis than someone that's abstinent from alcohol with Hep C. So that's really important for him to understand, maybe provide him a little bit more motivation for sobriety along with getting treatment for his Hep C. I think the fibrosis staging for him would be important as part of the treatment, especially with his prior treatment history, even though that's probably interferon ribavirin, which shouldn't really matter too much with the newer meds. But because of his pretty significant alcohol use, even though his labs look pretty good, we know that some of those people could be, stage 3, early stage 4 kind of cirrhosis. I think we'd want to know that so we're not under treating him like with Maverick if he's on a managed care plan, which would probably be the preferred med. So I think that would be important before he went through, and just for overall knowledge of his health and how you're going to follow through with him, even if he doesn't go on treatment. Do you need to do screening for liver cancers or watch his liver tests a little more closely than you would if he didn't have any fibrosis? Yeah, I think otherwise, that was all my big notes. Oh, Hep B vaccine too. Yeah, I saw that he was not immune. I don't know if he started that, but that would be very good for him to get vaccinated.
We were talking about vaccinations in clinic. That's a good reminder. Yeah.
Got it. So kind of in sum for this gentleman, history of cocaine use, although that seems to be in remission from what we can tell so far, severe alcohol use disorder, opioid use disorder, on buprenorphine with a kind of uncertain mental health history. And I think right now, increasingly suspicious, like at least a trauma or stress-related disorder, if not PTSD, depending on how it's going to manifest for him. And I think right now the struggle for us is really getting him to engage in treatment, given that it seems from his history that he has a really low self-efficacy. And so kind of things that we've talked about is trying to tie, whether it be medications to therapy appointments or kind of escalating intensities of treatment in that realm, as well as kind of tying that to adherence to other types of medications. I think this is somebody who really needs a lot of structure going forward, but I think there's going to be lots of discussion about him going forward. With that, we're going to kind of pull that together, and we're going to transition now to our didactic for today. So if you have any other questions, please feel free to send them in. But I'm going to hand it over to Jesse Powell now to touch on a couple of really key things around Hep C. And one of the things that we're going to try to do in our ECHO is at least once a month, we're going to bring Jesse or one of his colleagues back. Because I think one of the things that's so often comorbid with what we're seeing with opioid use disorder is hepatitis C currently, but even Hep B is not uncommon. And so I think thinking through how do you want to manage that when that can be a life-altering disease process for our patients when we're trying to stabilize them from a substance use perspective. So with that, I'll kind of pass it off to Jesse, but we're kind of looking forward as this is a first of hopefully many kind of monthly interventions. So if you have patients on Hep C, one of our goals is that down the road each month, you'll be able to present those Hep C patients. And right now, one of the state requirements is that you have to have a GI specialist or an infectious disease specialist sign off on your treatment plan. And one of the hopes that we're having, and we're even broaching this discussion with the state Medicaid director, is that would this be sufficient to kind of be that stamp saying like a specialist approves. So please bring your cases that you have related to Hep C, and hopefully we can kind of discuss this down the road. But Jesse, to you.
Yeah, great. Thanks, guys. Thanks for having me. It's really exciting to be here and talk with you guys. I do have one disclaimer on my slides, and that is I have a grant through Gilead that's actually looking at improving screening in hepatitis C, linkage to care and treatment in our homeless shelters. So it kind of fits in with what you guys are doing here too. So the topics we'll kind of run through today is like we're going to just look at our routine screening labs, kind of the initial workup with a Hep C patient you'll get in clinic, and then maybe just they'll touch on some management of that chronic infection, even if you're not ready to go through treatment for them, and then kind of who we should treat or how to treat them, or who we should treat and when to send them a little bit, and then kind of specifically to touch on what are the roadblocks for treatment and substance use. So with screening, everyone's pretty familiar with the Hep C antibody test. It's not infrequent that I get a referral to my clinic though with just a positive antibody test without that follow-up PCR. So it's always important to remember to obtain that Hep C PCR before you send people on to referrals. And if your lab has it available, there's antibody with the reflex PCR on it, so you don't even have to worry about going back and ordering that, which is great. So I always encourage the people here at Hennepin to order it that way so they don't have to worry about it. And if you think someone's acutely infected, the best would be to repeat it in 6 months to confirm acute infection before, to confirm chronic infection before you send them for referral. I think that, and that'll go into before you can get someone approved for treatment as well. We have to have documented chronicity of the infection before a lot of the insurers will approve it. So my initial workup, these are kind of the things that I routinely get. Genotyping is just, the genotypes 1 through 6. I'm assuming everyone's somewhat familiar with those. Used to be much more of an issue with our treatments, but now with the meds we use today, they're all we call pan-genotypic, so they'll cover all of the genotypes. So it's not as necessary of a lab, but we still end up with some of the insurers requiring it for whatever reason. Always be sure to screen for your other chronic, or for A and B for immunity, or chronic infection with B and HIV. Because we want to make sure we're treating correctly with B. There tends to be some risks there if you started someone at Hep C and didn't know they had hepatitis B as well. Routine labs, your regular kidney function, CBC, liver panel. I put in plus or minus an INR. I think that's a good lab if you're suspect maybe they have like more advanced liver disease to kind of look at that synthetic function. But if you had like a 23-year-old that only been using for a couple of years or something, I don't think you have to pull that lab necessarily. And I also put in plus or minus on the ultrasound, and Brian, I can go back and forth on this one a little bit. I think for like the really young people, I don't know if it's super necessary, but I always like to get a baseline ultrasound because I worry that over time, if they continue to drink or if they develop fatty liver and get a lesion, it would be nice to know if that lesion has been there for 20 years or if it's actually something new. But it shouldn't impede treatment for most patients. I think we shouldn't be something we're using for, before we decide to treat. I think, just getting some fibrosis staging is what would suffice for that. So with fibrosis staging, there's a lot of options we have out there right now. There's some really cheap and cost-effective ones in the FIB4 and APRI, which we'll talk a little bit about. FibroSure is a blood test that's it uses a complex equation with multiple different labs to predict the fibrosis staging of a patient, and it's a good test if you don't have access to ultrasound elastography. But the FIB4 and APRI are much cheaper than that one. So and they pretty much have the same predictive value for advanced fibrosis or not. So I kind of tend to just use those if I don't have access to an ultrasound or elastography. We here both have a FibroScan, so that's what the ultrasound elastography is. It's a great non-invasive tool for fibrosis staging, and it takes the place of biopsy now for us. And so biopsy being at the end there is hardly ever used. And for you guys, like especially the outstate people, I wouldn't recommend you have to biopsy everyone to prove fibrosis. I would start with those non-invasive ones first for sure, and then if you have concern, then go on to biopsy. So we won't spend too much time on these, but you can, if you have access to up to date, or you can Google either of these equations, the calculators, and plug in the data for the FIB4 or the APRI to predict the fibrosis staging. With APRI, I think if you're under 0.5, it's really pretty good for like saying you don't have too bad of fibrosis, and I think you could get away with treating for less time. But anything above that, you might have to look at sending them on for some more in-depth fibrosis staging, either a FibroScan somewhere or biopsy, I guess. Or I think in the amount of time we have, it's a little hard to communicate like how we can assess for fibrosis. I think it should be a separate topic when we go more into depth on treatment. So we'll kind of leave it at that. But there are tools out there that you guys can use to assess your patients. You want to add anything to that? Do you have any?
No, and I think it's really helpful because I think the biggest thing is when people are at risk for cirrhosis. So whether it be a long IV use history, heavy alcohol, something else involved, but especially for the young patient with IV heroin, methamphetamine, the risk is incredibly low. So essentially what you have to do in order to even think about treatment is you just have to demonstrate that it's highly likely that they don't have advanced fibrosis, in which case the APRI is the AST to platelet ratio index. So essentially you're getting liver functions and a CBC and you're done. And the same thing for your FIB4. And essentially that's has an extremely good sensitivity. So if your FIB4 is less than 1.45 or your APRI is less than 0.3 and arguably even less than 0.5, you don't even have to go any farther in terms of the advanced testing. And so I think the great majority of patients are going to fall in that range, and that's where it's really easy for almost anybody to be treating, because that's the main driver for changes in your treatment plan.
Mm-hmm.
Can I ask you a quick question just to follow up on that?
Yeah.
So, hey, Jesse, this is Ryan Kelly. So just to clarify, so, if someone likely is a relatively, in the last couple of years, new diagnosis, I had been under the assumption that a lot of insurances require imaging of some sort and wouldn't take just the opera. Is that false?
I'm not familiar with any of the insurers requiring like an ultrasound prior to treatment. Some of them will use like ultrasound and a combination of labs or like some clinical findings to prove that they don't have cirrhosis. They'll accept that. So that may be what you're seeing, Ryan. But I think if you were able, if you just calculated FIB4 APRI and showed that they had a high predictive value for no cirrhosis, that should suffice.
And should suffice is not necessarily the same thing as will suffice.
Yeah. There's nothing that will in the realm of Hep C med approval.
But right now, and I think this is one of the reasons for ECHO, is right now they require the subspecialist in order to do this. And in those offices, usually that comes with it. So our goal is to try to help you treat your patients where you are. And that's where a lot of this comes in, is we'll find out as we start doing this more. But there's no clinical reason why you necessarily need the advanced testing for advanced fibrosis.
Yeah. I think just to go like off of what we were talking here, like for APRI and FIB4, it's great for you guys like to do the treatment, but if you have, and not necessarily have to do anything beyond that, but if you have people that are in these middle grounds, I think it is important even post-treatment that you're coordinating with a specialist, or at least, or keeping them in your clinic to continue to monitor them, because they're not 100% tests, so it's a little bit muddy in between. In the stage 2 to 3 groups on these tests, it's hard to know for sure where they're at. So when we look at like just what would you do with this your guy, the case that you presented that you're not ready to treat, but you just kind of want to watch his liver disease while you're getting him teed up for treatment? I would, routine lab wise is, there's nothing that, if he doesn't have cirrhosis, that you really have to be watching for very frequently. I would just do like some liver panel on him like once a year or something. I never do routine PCRs, and you'll see that a lot with people. They kind of check those every 3-6 months. Sometimes it has no value in like predicting like disease severity or worsening the disease. So I would avoid doing that. Fibrosis staging with these like non-invasive tests like we've been talking about, I think, like a yearly check on those is probably appropriate as well. To, immunizations, which we touched on his case with hepatitis B. From the general medicine standpoint, I think it's really important that we're thinking about routine cancer screening, monitoring for diabetes and hyperlipidemia in these patients, because we know that Hep C has a much higher rate of diabetes and has some correlation there with hyperlipidemia as well, and possibly some solid tumors. So make sure they're getting their colon cancers and mammograms and those kind of things when they're needed. And then just basic education. It's like easy to forget, like they may not have any idea how they can spread it, even though they came in with IV drug use or whatever. Right? Cover their cuts, don't share toothbrushes, razors, fingernail clippers. It's not just needles, it's syringes, it's cookers, it can be crack pipes or straws. Anything that could injure that, fragile mucosa in your nose or lip could bleed onto those devices as well. And then, anyone that's in a monogamous heterosexual relationship, kind of, make sure you put their mind at ease about their significant other. They didn't give it to them through vaginal intercourse, assuming they don't have, open sores on their penis from herpes or having sex during menstruation or something like that. So on the who to treat, so the AASLD makes a really broad recommendation that all patients that have chronic Hep C, except for those with short life expectancies that can't be remediated by the treatment of the Hep C or transplant or by other directed therapy, should be considered for treatment. So this patient definitely is fits in the consideration category. We're trying to be more aggressive and get after get more access for these patients. And we talked about substance abuse and treatment already a little bit with these, how, some of these plans require abstinence from illicit drug use prior to approval. We'll see typically with like the managed care plans in our state, 3 months of an inpatient treatment, and then or 6 months just on their own before they will approve the medicine. Some of them even will say no even with marijuana, but others don't really look for it. If you're getting prescribed drugs that show up on the drug screen, even like THC or benzos or opioids, amphetamines, that's acceptable. You just have to show that they have prescription. Nicotine is not an issue. And then, some of the plans will even make you do a urine drug screen to prove that they're clean. So that's kind of where we're at as far as being able to get it approved. But like anything in this world, this isn't cut and dry. Like if you have someone that you think is really motivated to do treatment, and I think Brian and I both have been able to do write appeal letters and get medicine approved for people that don't quite fit these boxes. So you can get around it and get medicine for people. You want to make sure you're true to yourself and choosing a candidate you think will make it through.
Any other questions? Thanks, Jesse.
Yeah.
Got it. Hearing none. My hope is that as folks get more comfortable with this, and especially as you start focusing on buprenorphine and they start stabilizing, I've spoken with lots of docs that treat Hep C and use buprenorphine. And oftentimes one of the earliest wins for people, especially when they're coming from a more unstable situation, is they know if I'm engaged in 3 to 6 months and I can stay sober and absence from these other substances, then I can potentially get treated. And it's one of the earliest definitive, clear-cut wins they can have when there's so much fear and misunderstanding around Hep C. I know we've had multiple patients come in and say, like, I know this is certain death and it's incurable. And we're like, actually, no, we'll treat you right here in the clinic. And it really can be a big marker and moment of opportunity for engagement. So our hope is that as you start seeing folks and treating them, please bring your cases and we'll be able to help you and get kind of that approval. You can kind of write your appeal letter to your insurer and see how can we help you take care of these folks, especially as they're stabilizing. Because really a lot of folks with Hep C, it's the people that are just now stabilizing are actually the people that are driving the epidemic. For any person that's an IV drug user that has Hep C, they're probably transmitting it in a lifetime to at least 20 more people. And so that's where we're really trying to target and stabilize these folks for treatment and kind of wrap those services around them. So that's really our hope. Any other questions, thoughts?
Excellent. Thank you all very much.
Thanks, Marshall.
And thanks for the feedback on the case, everyone.
Great. And I just want to give one hype that Lori Wilhite reminded me of. All the Hennepin Healthcare pharmacies are actually going to start selling 10-pack of syringes, as well as a small Sharps container without an insulin prescription needed for about $3.50 starting next Monday. So it's something where if you're looking for kind of risk management, I know in the injection drug community, people oftentimes look to Southside Community Health and other folks in terms of the needle exchange, but that's also in terms of like how can you promote safe injection use while trying to stabilize people. That can be an opportunity. So thanks, Lori, for that reminder and that announcement. Thanks again, everyone. We'll kind of give the gift of time. Have a great one. Look forward to seeing you next week with Dr. Pilkus. Particularly if you have any difficult pain cases where you're struggling with high-dose opioids and when to switch or how to switch to buprenorphine. I know I've got a few that have already got lined up and asking Ann about, but I'd more than prefer to be able to kind of talk about your cases. I've already got her on speed dial. All right, well, thanks, everyone. Hope you have a good one. Take care.
Sorry, I had a surprise meeting.
Oh, fun.
It took me a while to get out of.
Yeah.
I'm like, well, it'll just take 5 minutes.
Yeah, right.
Well, now I know this was related, so I'm not going to be worried. When to provide advice
Take care.
or reassurance.
Hey, Kurt, how's life?
He wants to retire. Oops.
How is life?
Yeah.
How'd you get a day off?
It's been pretty busy.
Yeah.
What do you do? We've had this huge influx of patients. Just huge.
Like how many?
Where they all come from.
Are they how far away are they coming from?
Most of them are pretty local, but a lot of really tough people out of prison and just kind of a little bit different crowd. So I think from that standpoint, it's just been interesting how many more patients we've had here lately.
Yeah.
I think we've got 5 or 6 new ones in the last 5 or 6 days.
Yeah.